Kevin, can you please start us off with how are you using OncotypeDX to dictate your treatment in premenopausal versus postmenopausal women? And how does this change if the patient is node positive?
Yeah, I think what you have demonstrated here really is the approach. For those patients, we base this upon menopausal status, and we have data from Responder that those patients who are node positive as well, that have 1 to 3 nodes involved, if the recurrence score is less than or equal to 25, that we can, think about safely foregoing chemotherapy. And for our patients who are premenopausal, who are node positive, we have this conversation about chemotherapy. That is a common question that comes up. Is there still a role for checking oncotype in patients who are premenopausal? And I think it's informative and prognostic, and I do it with patients. And of course, we don't fully know whether the benefit that we're seeing is due to this ovarian suppressive effect or not. Why we're doing the OFSET trial, which is randomly assigning patients to do ovarian suppression and endocrine therapy with or without chemotherapy to definitively answer that question.
And I actually have a patient enrolled in offset trial because we don't know the right answer here. We believe that ovarian function suppression in that early subset might be equally good, but we're eagerly waiting on the data. Kevin, is there any utility in ordering this recurrence score even on early biopsy to expedite the process, or waiting on full specimen post-surgery is the only way to do this right? Because we were doing some of this during the peak of COVID.
Yeah, yeah. In Responder, for instance, it didn't matter where you had the biopsy from, right? It could have been either the core, could have been the surgical resection tissue. And so I actually had this come up in clinic this week for a patient who's waiting for her surgery. She really wants to have the test. I said, let's go ahead and order it. But if you end up having 4 lymph nodes involved, we may cancel the test just to get the ball rolling. Sometimes I have done that.
And then when we're using these tools, we have other tools like MammaPrint. Should we rely on those other tools in any particular settings outside OncotypeDX?
Part of the ASCO guidelines are to use a genomic assay and stick with that genomic assay. This is a common question of, oh, I had this, should I send the other test to help inform this? And really, I try to stick with that assay. I think for both of those tests, it's important to keep in mind that it is not just the score, it's also the clinical features as well. So, in the US, we have RS-Clin, which incorporates clinical and pathologic features for node negative. As of January, the node positive is also available for 1 to 3 nodes involved. The way that the MINDAC study that was conducted for those patients with MammaPrint, it was also the incorporation of clinical risk. And so I would say right now, both are reasonable options. I tend to use the recurrence score primarily because I really like the RS-Clin tool. I find that very informative to discuss and individualize with my patients. There are other studies looking at the role of MammaPrint as an integral marker. I think this will continue to play out, including the role of IO for hormone receptor positive disease. There's an NCI study looking at that assays.
And then as we're talking about adjuvant treatment, at SABCS 2024, we also saw data supporting that if your recurrence score is high, anthracyclines might play a role here.